Good morning and welcome to our monthly live broadcast for endovascular interventions here from Mount Sinai Hospital in New York City. I'm your moderator for the day, Vishal Kapoor, joined by my partner, Dr. David Song. So we are again excited to have another interesting case led by Dr. Krishnan and the team, Dr. Guja and Dr. Rao there assisting him as well. Before we go into the cath lab, just a gentle reminder for our annual New York Endovascular Summit, which is scheduled for the coming September, from September 24th to the 26th. You can go to our website, nyebs.org, and register, look at the agenda. We have a very vast agenda this time involving fellows boot camp, aortic boot camp. We have a therapy-based learning. We also have dedicated venous symposium, which focuses on venous disease as well as pulmonary embolism, the hot topic that's coming up in all these endovascular conferences. Of course, a great faculty, international faculty coming all the way to get their expert opinions, especially on the PAD, below the knee, and a full dedicated day for below the knee critical ischemia. So a great conference. A great place to network, learn, share, enjoy. And please log on to the website, register, and we hope to see you in New York this coming September 24th to the 26th. So from now, let's talk to PK. Morning, PK.
Morning, Vishal. Morning, David. And thanks so much, guys, for that nice introduction. Again, I'd like to reiterate what Dr. Kapoor said about the conference. We'd love to see all of you at the conference. Obviously, a lot of you follow us and are participating in these live cases. So opportunity to really, spend time with everyone, the faculty, and really collaborate and learn together, which is the nice thing. Really, the goal of the conference is to come up with algorithms, algorithms that we all can use. And this is a great case that's going to illustrate a difference of opinion in algorithms, likely. But I think that this is kind of why we're in that crossroads in our field of PAD, where everybody's great at doing things, but which is the right way? Not necessarily the right way, which is the most efficient and safe way to do things for our patients. So anyway, but with that introduction, I'd like to introduce our team. To my right is Dr. Karthik Guja, who's the Director of Endovascular at Mount Sinai South Nassau. To his right is Dr. Ajit Rao, who and these two have always been with us. And Ajit is, as you know, is the Director of Vascular Surgery Research and an Associate Professor of Surgery here at Mount Sinai. Behind me is Ray Lascano, who's been with probably every single endovascular live case that we've ever done, along with Karthik. And then our nurses today are Reka and I'm blanking here. I'm sorry,
Denisa.
guys. And Denisa, forgive me. It's an age thing. And Denisa, I just had a load of it this morning and I forgot her name. And then and we've got Damien outside, and we've got Fausto, and of course our endovascular fellow today is Sanchit. Sanchit is one of our 4 endovascular fellows who again has been incredible in his ability to grasp the concepts and work really hard to take care of our patients. So without further ado, I'm going to go ahead and get started with the case. Sanchit, if you can present it.
Yep. Good morning, everyone. So we have a case here with our patient is a 65-year-old male with a past medical history of hypertension, hyperlipidemia, diabetes, and CAD with multiple PCIs. His latest PCI was to a circumflex CTO on 17th of July. He presented to us with lifestyle-limiting intermittent claudication in the left limb. With a Rutherford class 2 grade 4. This was a progressive intermittent claudication progressing to rest pain despite maximal medical therapy. On the bottom left are his home meds, and right there next to it are the lab values, which are normal CBC and a normal BMP. We also have non-invasive testing, which showed markedly reduced ABIs on the left side, and a duplex scan, which showed no detectable flow in the left commoniliac artery consistent with occlusion, and of course, dampened monophasic waveform in the vessels downstream from the iliac vessel. It also showed a distal reconstitution. This is our diagnostic DSA. So here we can see the catheter is placed in the distal aorta. We do see that there is a ostial commoniliac artery occlusion on the left side, but it does reconstitute distally. There is also disease in the contralateral the access site, common iliac artery at 2 spots proximally and somewhere in the middle. It is important to recognize the morphology of the cap here, the distal reconstitution, healthy segments, and also to identify contralateral disease, as it all helps in case planning. Then we can move on to access sites. We often use a combination of either of these accesses. We'll talk about each one of them. The ipsilateral femoral axis is the closest to the CTO. It gives us the best pushability. It gives us direct device delivery, but it is limited by the morphology of the CTO. If it's a hostile CTO, long CTO, it can be less helpful. The contralateral femoral axis gives us an excellent angiography. It is very useful if we are thinking of upfront kissing setup, but it is limited by tortuosity of the iliacs and, of course, the angle of bifurcation. And then comes the radial and brachial axis, which comes with the merits of all radial axis of low bleeding, excellent angiography from above, and the ability to engage the cap from above. But it is also limited by tortuosity of the distal aorta and the size of devices that can be pushed through it. Now, zooming out a little and just talking about the roadmap of how we proceed with complex pathology of this kind, we always want non-invasive testing to start with, which helps us plan the case. And then based on that, we decide our primary access sites, which we discussed in the last slides. And then we go for the crossing attempt. The goal always is to stay true lumen, but more often than not, we do use the dissection re-entry. And then if the re-entry is predictable based on the wire behavior and the morphology, which that is great, but if it's not, we use the re-entry devices. And the end goal, of course, is to do destination therapy from healthy to healthy segments and remove the gradients. So just talking a little bit about the dissection re-entry methods, it is imperative to define the proximal CTO cap. And then based on procedural expertise, sometimes we can use multiple angiographic angles and IVUS to look at the morphology of the cap. We often start with a hydrophilic wire and then escalate as needed for more pushability. It's always recommended to use a support catheter with it or a long sheath. A little bit about the B-back device. We always want to re-enter deliberate in a deliberate and intentional manner. If there is trouble re-entering the lumen, you want to use a B-back device which has a directional component to it where you can direct the needle into the true lumen and wire into the true lumen. And it should be considered for flush or ambiguous caps, long subintimal course, and failed multiple attempts at spontaneous re-entry. Talking a little
so
bit.
why don't we stop there for now? We'll come back to the data. I think that's a great introduction, Sanchit. It's a really fantastic job. So I'm curious. I mean, let's see. We've got Karthik's going to play the initial film. Everybody saw it. So what are the thoughts in terms of access points and other things? Vishal, Ajit, I mean, what are your thoughts?
No, I mean, I think angiographically, like Sanchit showed and like Karthik is showing right now, I mean, it's pretty much a flush occlusion at the left ostial region. And you do see some reconstitution in the distal common or the proximal external. It's technically proximal external iliac right there. So from an access perspective, if we have to start thinking about intervention, but I think coming from below looks more favorable. But of course, visualization of the proximal cap is essential. So having two accesses for sure stays there. The question really arises is how much into are we going to fix the right? Are we not going to fix the right? That will determine our choosing the size. Remember, at the end of the day, we have to choose the size of the sheets and the accesses, everything. So are we going up front, have bigger access on the right side because we plan to do both together, or we just keep the right side or the contralateral side of the lesion as diagnostic and focus all on the ipsilateral side? So I think very important topics to discuss and strategize and then come up with a plan and have a plan B or bailout in case there is a shift in strategy while we're doing the procedure. So great points. But in this case, two contralateral femoral accesses will be my first choice. If there was an issue with the right or the contralateral side, then radial or brachial as a backup. Or if I can go from below, then radial brachial probably as my plan B to come from proximal part and go down distally.
Ajit, what about you, man?
Yeah, I do something very similar. So if it's like a unilateral occlusion, one side, then I'll do bilateral femoral access typically. One for the diagnostic and then the other to try to cross. If it's bilateral, then I'll definitely get arm access, so that way I can cross and also do the pictures. But I like doing bilateral just in case you have to do kissing stents or something like that, like in a lesion like this, just because I think it's easier to do it from bilateral femoral access than trying to come from the arm.
Right.
So, but I certainly think there's multiple ways.
Anything different?
No, I always go radial. I think all you guys know that. I always prefer radial for iliac. I always have a groin axis and a radial axis. I usually try primarily from the radial, especially if they have a beak. I think it depends on where you're trying to wire it from, below or above.
And David, yourself?
So in this particular case, I agree bifem axis is ideal, and given the grouping of the collaterals at that ostial left iliac, I would prefer to cross retrogradely. Since it's also an ostial lesion, if we can cross retrogradely, I would also plan to fix from the ipsilateral left common axis side. So in that case, that would be my preference, but bilateral access, like Dr. Rao said, in case of bailouts, would be ideal as well.
So for the audience, I mean, you can see all the divergence in decision making, as you can see, just on access alone. I think Ray and I generally in these kind of cases would go bilateral access below, but in this case, you have the right that we're not going to fix today because of multiple reasons. I think that with the complexity of this case, the fact that it's a live case, I think we'll just concentrate on the lesion that's at hand right now, and we'll bring them back. So because we had bilateral disease, we're gonna fix the next one either later this week or next week. What we're planning on doing is this. So I personally chose arm access because I don't agree with Karthik. I don't think these should all be crossed from above every time. I think that there's a lot of issues with crossing from radial, and we should discuss with that because if you don't really have a bailout from the radial coming down in terms of sizes. The VBXs, obviously, they can go through 6 French sheets, but sometimes in larger, no VBX, no, they go through 6.
No,
They
six.
started
They 6. Most of them go to 6 now. So.
The problem is the larger sizes, especially do not. And so it depends on whether you have a CT imaging, like Sanchit was saying. If you have a CT and you have a confidence in terms of the size of the iliac, then I think you can confidently go from the arm. But when you don't, I think you have to be careful for those at home. Obviously, Dr. Guja is incredibly experienced, and obviously he's making these decisions out of years of experience. But I think from home, the safety really comes in as the priority because this is one of the few areas I think Ajit would agree. This and the aorta, where you can really cause a lot of problems for the patient very quickly. Obviously, God forbid a perforation or anything like that. All right, so now go ahead, Vishal.
Just one question, PK. Just looking at the angiogram itself, and especially from a surgical perspective, the route of access, meaning the route whether going retrograde or antegrade, how much determinant is that lumbar collateral supplying your external iliac?
And that's a great question.
Biggest, because if you think about it, and I'm sure we can talk about the option saying if we go retrograde, we dissect. Is there a chance of shutting down that collateral and not re-entering? So is it more favorable to come from the top and trying to save it? Or you don't care about it? I'll still go straight, go from the bottom because it's more favorable. And so how that plays into your decision making, I think is a very important question.
I think Ajit will be great at answering that, but I just want to show you the picture so you can understand. This is the aortogram, and you can see the lumbar collateral does not fill the internal iliac. The internal iliac is actually filled retrograde.
That's a better picture.
Through the other collaterals. So
both the internal iliacs are gone.
So both the internal iliacs are gone, but the one that fills is really through that other large collateral.
Is that the IMA?
The sacral branch, right?
It's the IMA.
That's a sacral branch, isn't it? Coming down.
I think it looks more like an IMA.
Yeah, you're right, but I think we're talking about that other
Correct.
the large one
the other large one which is coming down.
Oh, that's the
pelvis.
That's actually the one
robust.
which is actually coming back sometimes and filling it too.
Right, but this is the sacral branch coming
sacral
down.
branch.
So, but I think it's a good point. I mean, you definitely don't want to take it out until you know you've crossed. I think once you cross, you have to cover it, because it's right at the origin, or you're going to be very close to it. But you should try to preserve it. But I think there's a little nub in there, so you should be able to get past it.
And that's part of the next thing. So what we decided to do was we decided to go in with the catheter. You can see that Ray and Sanchit did multiple views here. And you can see we have now a straight a angled tip catheter up top, switched out the pigtail, and you can see now you can start to see the actual nubbin. And there's Karthik injecting into the nub, and then we're injecting from above and below. And here's a roadmap to show you where the nubbin is and what we're doing. So I guess go ahead.
I was just gonna ask one other pre-op question. Do you guys get CAT scans routinely for iliac interventions or selectively? Or
that's a great question because Sanchit presented it. So let's talk about that. How many of you guys get CAT scans?
I do. As long as the creatinine's okay, I would just get a CAT scan. Sometimes logistically there's issues trying to get a patient back and forth, but ideally I would get a CAT scan with a normal creatinine.
I get it too. For all aortoiliac cases, I get a CAT scan. So
I just think you have all the information ahead of time, like the size of the iliac, the calcium, and so you can just have everything ready in the room.
You can just plan it very well.
Yeah. Well, honestly, I've never gotten CAT scans in my life for these cases, and I'm not saying that's right. It's just like logistically, it's impossible here for us to be able to get CAT scans, so it's not been something that we've done. And I agree with you. I think it gives you a lot of information. So now we're going to inject from above and below. Give me some dye.
So what is your strategy, PK? You are primarily going antegrade, retrograde? Or we're still trying to decide?
No, that's what I want to discuss, because that's why we presented this case, right? So the question is, I'm going to show you guys. So remember, for those at home, these angle catheters are very important. We got an angle catheter in the proximal cap, angle catheter in the distal cap, and what we're trying to do is we're trying to connect the dots. So you can see here that the visualization is very, very important, and this is going to help you with the wire choice. Similar to coronaries, there's a wire algorithm that you guys, everybody at home should start to develop in order to be able to cross these similar lesions. So I'm going to give you a roadmap here, and this is an advantage we have that we don't have in the coronaries, is actually being able to give dye and see the cap. See, there you, it seems like a short segment, but it's extremely, extremely calcified.
Yeah.
So the question now is, I want to ask you, based on this, Ajit, what would your wire algorithm be?
Yeah, it's a great question. So I think it's all about wire escalation. In the iliacs, I find that I'm more often going straight to 035, to be honest. So I'll use like a glide wire vertebral glide path versus like in a tibial lesion, I'm going to start with obviously like a 014 command or something and escalate up. But in a lesion like this, where I don't want to cause a bad dissection plane and then end up having to use a reentry device or compromising the collateral, I probably start like with probably a V18, to be honest, and then escalate from there.
So what are the characteristics of the wire, Jit, that you're looking at?
So for this, with all that calcium, you definitely want something with like a lot of gram, a lot of support. So I would, like when I'm doing something in the leg farther down, I'm going to start with like command wire. And here, I don't think, at least for me, I just haven't had much luck with it. So I think I need something a little more.
So you'd go with V18. What about you, Vishal? David? Why don't we start with you, David? What about you?
So, being a non-surgeon, I would be very careful here with this very complex calcified lesion. I would actually probe with the 014 system first. My wire of choice here, understanding that this is a very calcified CTO, would probably be something like a Confianza Pro 12, just to see how the wire behaves, to see what direction it's being deflected in, before I'm more aggressive in escalating to a 018 system. That's how I would initially start with this lesion.
Okay, Karthik, Vishal, anything? But what characteristics of the wire are you looking for?
So once again, like Dr. Rao said, I agree. I would look for something for a strong tip load in order to kind of break through the calcium, but I wouldn't really go for a hydrophilic wire up front, because I don't want it to go into planes where it's not supposed to go, or deflecting in a direction where I'm not comfortable with. So the Confianza would be a good start for me, where it's not really coated, but does have some tip strength in order to kind of break through those calcified planes.
I do it like Ajit does. I always go with 018 first.
Yeah.
I don't think 014 has the strength to go through these vessels, and they're also large vessels. You create multiple dissection planes, and then you get stuck with it.
And it seems like Vishal agrees too. So I mean, look, again, those at home, you see the divergence in opinions on what we're going to do. I think we all agree. I think the commonalities in that statement, I mean, you guys correct me if I'm wrong, is stay away from a hydrophilic tip at this stage, right? Yeah. Although V18 is hydrophilic, right? So it is hydrophilic, but it has an 18 gram tip, which is again a penetrating wire. The second thing is again, use a high gram tip wire to perforate the cap, or to cross the cap, and then be able to steer it. So 018, 014, I mean, I think personally, I think that these days you have a 60 gram tip wire with a Shahi, which I think is an 014 wire. So you can do 014, 018, doesn't really matter. So so why don't we go with an 018 penetration? And now, would you strive from above or below? Question.
So here, I think the only reason, as Vishal was saying, because if you go from here, there's so much calcification. That's why I always have below axis, because you want an aortic, you want to be ready for a perforation if it's possible.
Sure.
So you should never primarily do these cases from radial.
Yep.
Primary radial access is not a good idea, as you said. You should always have your groin access available for these kind of cases. But when you go from below, you can go into an odd plane, and you can probably have like an eccentric entry into the aorta. I think when you do have a tip, it's a favorable. You come from above, you can always come to the midpoint of this CTO and try to go from below and meet it, or always snare it if you have to.
The injector. So
I think it's
Ajit, what about you, buddy?
Yeah, I'd probably start. I mean, I think you can go either option in this
So
case.
to me, the cap is favorable below.
Yeah,
Yeah,
but
exactly.
I was going to say I'd start below
The cap
because
is peaked, right?
and you got that little channel
Yeah.
there.
So
So
that's
to
what me
me-
and David were discussing. Is like below looks more favorable, and like you said, I
See,
mean
look at
above
that.
is
Yeah.
So below you have a nice thing, and then
And then I think you have more support from below too, right?
Correct.
Because you can park your sheath higher up.
Yeah.
and you can.
What do you
push-
have in the arm right now? Is it
We
a
just- we
Fasciculus?
just
It's just
have,
the catheter.
Yeah, so you
yeah,
don't have as much
We
support
didn't
with
put
the
an
sheath.
R2P because we were like, hey, let's cross from below.
And then,
Obviously, we can always upgrade, and
Right.
we can always do things that we need to do.
and then if you cross from below, you don't have to, snare the wire versus crossing from above, in which you do.
Exactly.
So it just saves
So
you
let's
some
see.
steps.
Let's see how this goes. I mean,
So,
But I
Vishal,
might
a
have just
question,
jinxed you now.
a question, just basic questions. I know because some people who are watching these cases are probably starting their career off in endovascular. So, when you do these kind of cases, the views you want to work in, what kind of views do you want to start working in, and how do you want to know it?
I mean, that's a great point. I mean, I take, especially in cases like CTO, complex cases, calcification, where you always should take multiple views to really find the real lumen, the real stump, the collateral, the origin, because sometimes it's so deceptive. You want to do ipsilateral, but sometimes you might have to do contralateral, especially if there's an internal iliac involved somewhere. So I think in these cases, I do orthogonal view, ipsilateral 20, 30. Then I do contralateral to really define my proximal end of the common iliac, my external iliac takeoff, how far would the stent go eventually, and as well as defining the stump. So calcification is a good marker, but at the same time, it's very deceptive as well, because you could get fooled by it. The lumen might be away from it rather than on it. So I think taking multiple views works great. But I completely agree with PK. The lower stump or a retrograde axis looks more favorable, trying to give you a little bit more, like Ajit talked about, the pushability, because you have a microcatheter going in. You're bypassing all the tortuosity of the thoracic aorta, the descending aorta, and everything
we're
plays.
going the right way.
Yeah.
So
But I think
you
you made
always
a
have a
good point.
bailout.
I think you made a good point. In this case, I can't tell what's going on with the hypogastric exactly, but if you have the option, you should always try to preserve it,
Yes.
especially in a claudication. So that, you need the obliques for to really see the origin of the hypogastric well.
Okay.
The opposite, basically oblique.
Yeah.
So Vishal, this is what I was telling when we go from below with when you have a stump from above, you kind of go on the side. So even if you entry, it's an odd entry point for you.
Correct.
To stand. And then it's just that ostial nailing the vessel at the ostium of the
Becomes harder.
iliac becomes a problem.
Give me a wire from above, guys. Give
Yeah,
me the same wire
that's
from
what I'm
above.
saying. You just have to
You
try
want
to
and
poke
start
around,
from above?
No,
Same
and then
way.
you can start.
Another penetration. I
Yeah,
know.
so what we'll do is we'll come from above and below, and then we're in a good position from below.
Yeah, I think you're in a very good position from below. Yeah.
So I think that this is a great example of being slow. See, notice the one thing I want you guys to notice is that none of us wanted to advance the wire. So when we didn't advance the wire, advance the sheet. So we're not creating a big dissection plane. It's an 014 little dissection plane, and we're going forward.
And I think,
Go ahead, Ajit.
No, I was just going to reiterate that. I think what you did was really smart, where, to me, your wire looked like it was going in a good direction, but before you went all the way up into the origin of the iliac, you took a picture from above, and then you saw you were a little to the side.
Yeah.
So taking plenty of pictures, especially when you're close to the re-entry point, is important.
Yep, and that's a great point, right? So here I'm gonna have a little. So we're just gonna go down, and listen again. You could say, well, why don't you have an R2P sheath? We've had a lot of spasm with R2P sheaths and things like that. So it's not really something that we want to do.
Torque. I'll give you the torque.
What wire are you using from above?
Same
penetration.
penetration.
Yeah.
And then what I'm gonna do here is try to torque the catheter down here a little bit,
and
like that. Yeah, like that.
So would you guys be okay
go there.
crossing in a dissection and re-entering, or would you just
There you
really
go.
try to stay in?
That's nice.
That looks a lot better. Well, I don't know. Let's take a shot from below now. So from below, we're
Yeah, I
going
mean,
to
it's
take
a
a
big
picture.
vessel, so you could be both sides in there, but yeah, it's just far away, just because of the vessel size.
So again, just a little bit of patience, right? Just to see what's going on, just to see where we are. Okay, we're going in the right direction.
Good.
So a little bit of patience, and then just see if it goes smooth. I'm going to pull this back a little here. Again, I'll ask Ajit whether he thinks we should advance. I think we should advance the catheter from above, right?
Did the wire go any further or no?
Yeah,
I'm gonna
going a little bit
wanted to
too
redirect the wire a
medial.
little bit,
Yeah,
It'd just be nice to see it kind of like close to that
Correct.
catheter
Yeah,
before you commit.
but the catheter is so big, right?
Do you even think the catheter is 035, right, and the wire is 014?
Yeah, we can switch out for an 018 wire, 018 catheter.
I think that's good.
I mean, this is such a big iliac.
I mean, you
yeah,
could
that's what I'm
also,
saying.
if you weren't like entirely sure, you could
There you go.
IVUS
That's
too.
a good
But
spot.
I mean, that looks
you're
really
in.
good.
You're in.
So I don't know now. Let's take another picture from below. I just try to be careful because you're in a little beak on the other side. And then you just want to be a little careful here, guys. Yeah, I think we're heading the right direction here.
I mean, not that you should feel like a sense of security, but it is a little safer crossing this way because you're crossing into the external iliac versus the aorta, where you could cause a
that's true.
dissection.
That's a great point, Ajit.
But you can still cause trouble here by propagating a dissection.
So the
We could
question
also-
is, should
always
we
make
snare
sure
the
that-
wire? Ajit, should we snare the wire now?
Do you think
We are
That'll-
there. We can.
We're on top of it. Look, two views.
So I think the best thing would be to probably pull that microcatheter, which is retrograde, to pull it back a little bit. So maybe it just falls into that plane of the microcatheter that just we have from down below.
We don't
See
have a
that,
microcatheter.
No,
I
we
mean,
have
the
catheter
support,
here.
the
He's talking
catheter
about
right
the
there.
Support catheter.
Support
Yeah,
catheter.
but no, I'm not even close to that right now, though.
But hopefully,
Yeah, see,
can you?
yeah.
I mean, the question is whether I think that's the only thing, right?
You're gonna, yeah, exactly.
I mean, I like your wire from above more.
Yeah,
Right.
yeah. Let's give it a little dive from below, guys.
I don't think you have to meet in the
I
middle.
think from below we shouldn't go because that's going off into the
Yeah,
side.
it's completely
Yeah.
side.
Give me a little bit dive from below.
I think I would just snare it from below.
Yeah.
if you
Yeah, that's
get
what I'm
into
going to
the
do now. I'm
catheter.
just going to snare it. Inject. Yeah, we're going to enter
then
right
we're
now.
gonna
Let's
enter
just
it right
enter.
now.
Yeah.
You want to take the catheter down?
No, it's
a
already
little bit?
entered. See, we entered. See?
There you go.
Nice.
There you go.
Nice.
So
Well, that's very
just entered.
convincing.
So now we can just snare it and just work.
So
No, that's the
helping
best
move
part about
catheter back
PK.
does help.
He says not to do it one way, and he makes me
Yeah.
he makes me look good by doing it the same way.
Wait, so who crossed it?
All right, so Ajit, would you snare it or would you
Yeah,
externalize?
I think you're definitely inside.
you're
Bring the
already
wire
in the
further
catheter.
down
No,
and then
I'll just
snare
put it, just marry it. PK,
Yeah,
can you
pull
pull
your
your
wire
wire
out,
back
yeah.
and see if you can go into that word tip catheter?
So what I do is I ask to open the snare, and by
Right.
the time they find it, if
Yeah.
I haven't
Right there,
gotten to
yeah.
the catheter, then you snare it.
You can do
Move
that.
the
Because
catheter.
it's a
Yeah, you
bigger
can
vessel,
kiss.
so
It's a
Yeah.
huge vessel.
it's going to be harder in an iliac versus
Yeah.
a
That's it.
tibial.
PK is very good
PK
in
can do
getting
it.
catheters in.
I
Try.
don't know about that. Car, I think, is the best.
There.
Do we?
Oh, hold on.
I'll get
Hold
to
on.
We
that.
have a snare, right? Okay.
So Ajit, why not cross from above here? Why not push the catheter down? We know we're in, right?
Oh yeah, I think
can,
you could.
but you might
Yeah.
not have.
But
the
either way, you still have to
pushability
snare it, though, right?
Yeah.
Even if you get the catheter through.
Let's see if I can push the catheter down. I don't want to do that.
You might not have the
Correct, pushability.
pushability to push.
All right, get the snare, guys. It's such a huge vessel.
It's a huge vessel. It's just floating around.
Yeah, it's
I
going
know,
to be
you're
hard
going
on
to keep
the
pulling back. Yeah.
Yeah. Let's just. Yeah.
Yeah, 20 should be good.
20 is good.
20.
Let's get a snare.
Really
Let's show
small.
how to snare it, and then we'll go ahead and just. Ajit, you want to snare for us?
Yeah.
You're much more facile with snares than me. So do you walk this catheter out, Ajit?
No, I think you can do it on this
it's
catheter also, no, Ajit?
Well, we can just.
Just push it in
I don't
this.
think it's
no?
long enough, no?
So
Yeah, we can just take it out. You can take the catheter from the bottom out,
Yeah,
and then I'll just
because-
give you the
Yeah.
snare catheter, and I'll
Yeah,
backload
because
it.
I think it's too
Microcatheter.
long, right? That
Yeah.
catheter is too long.
Yeah, it's not going to.
Damien, what's the length of the snare?
120.
Yeah, 120.
Yeah,
so
word
there
tip
you
is
go.
150. Yeah, so.
Do you mind holding that?
Yep.
I'll give you the cheater.
You want me? Tell me if you want me to pull the wire back,
Back
Ajit.
Yeah, let's just see how the snare opens up.
Good,
So you
there
have
go.
a 7 French sheath from retrograde left common femoral axis, PK?
That's what Ray and my usual algorithm has always been. 7 French at this stage. We go up together, and then because we feel that all the bailouts are available to us.
Yeah.
So we always do with that.
Can you advance my snare?
Sure,
There you
I
go.
will. Uh-huh.
Just until I see it on the screen.
That's
Perfect.
good.
Yep.
That's good enough. Just good.
Wow. Look at
Okay. Hopefully, can you advance the wire a little more?
I
You
will,
think?
sure.
And hopefully, it'll go through that loop there.
that. It's a huge snare.
It's a big snare. You got a 20.
Yeah, it's a 20. We could have probably
Wow.
done 10
Like
or
a
15.
10. Yeah.
But little downside to using it. I don't think it's in.
You can
we
make
have
the
to get
snare
it smaller.
smaller by pulling it. No, you can
No,
make
the
it
problem
smaller by
is-
just pulling it.
The sheath is too close.
No, it's in the external. If it was in the common, then your 20 is fine.
Maybe
But
that's
this
a little
is-
better. Can you pull the wire back and then try it?
Mhm.
Almost, yeah.
Just trying to twist it around and see if it.
You want me to make the snare smaller?
Yeah, we can also do that. That's a good idea.
That's better. Now try it.
And sometimes if it catches a wall, it will.
Look how off we are.
No, it's just a big vessel. No, you want.
I don't think we're that big.
Do you want
Yeah, that is a little
That is a little off, man.
strange.
Wanna
take
You
a
want
picture?
to try higher up because I see that.
The question is, am I floating in the belly?
I don't think so. What about up here? If you pull the
Let me puff. Okay.
Yeah.
there, that looks better.
That looks 100% better.
You're good.
There you
Yeah,
go.
Okay, we got it.
All right, now I'm
Yeah.
going to feed my wire to you.
Yeah, you're gonna
Oh,
feed
wait,
it.
wait, but,
No,
but
just
it's a
let me-
stiff
let me-
wire, right?
No,
So-
it'll come. It'll
So
come.
no, one of the things, guys, it's a very stiff wire, so this won't bend into the sheath. So I might have to pull the wire back a little bit.
Yeah. Do I
Yeah,
have
now-
the floppy part of the
Yeah,
wire?
now you do.
Yeah, you do. You do.
Okay.
And now try.
Okay.
I'm going to
And you're
feed.
feeding it to me, and
No,
back.
I don't think it's going to drop.
You want to pull the wire a little bit more, PK.
okay,
let me
I'm
pull
gonna
the
open
wire.
it up a little
A little
bit.
bit more, so you can directly just pull it into the sheath itself.
Okay, that's
now
good.
try it.
Uh-huh.
A little
So
bit
this is
more.
very important to those at home because this is a very
Yeah.
stiff
Stiff
wire.
wire.
Now you got to pull the wire back a
It
little.
won't come.
Yeah,
It won't come.
okay.
Yeah, let me pull the
Ajit,
wire.
it's very
No,
stiff wire.
no.
No, just push a little bit in, Ajit, so the whole thing will come into the sheath.
He's just
Push
trying
a
to make
little
it
bit
more
in.
coaxial. Yeah.
More coaxial to the sheath, a little bit more.
No.
Yeah.
I don't think it's going to
Yeah, now it's better. Now it's
Okay,
better. It'll
One
come.
second. That should be good. Just if that tip of the wire goes in, we'll be okay.
Yeah, that's it.
Yeah.
There
Okay.
you
That's
go.
what it is.
There
There we
you
go.
Okay, good. I'm
You want me
feeding
to-
you now.
you
Oh,
want me
no,
to
no,
hold?
you're not in.
No, you're on the other
that's
side. You're behind it.
Okay.
Yeah, that's a very important point that PK brought up because it's such a stiff wire.
No.
Still outside.
PK,
So the
what-
question is, Ajit,
PK,
why
what
don't
you can do is you
why
can
don't-
push the catheter from
Yeah, why
above
don't
now
you
because you
rail
have
it?
a
I'll
rail.
push the catheter down.
From above,
Yeah.
and then you can put a
Okay.
hydraulic wire, you know?
Okay.
So
a good idea.
pull the wire, brother.
Yep.
Keep
Yeah,
the
so
rail for me.
rail
All
it.
right, I got a rail for you.
It's not going.
I think you.
Wow. Nope.
No,
No,
take
You can
a
always
trailblazer.
exchange the catheter into
That's
a
what I'm
wire,
going to
right?
do, yeah.
Give
Want to try
a
one more
18
time though?
trailblazer.
Because I think
Let's
Over
try.
eight,
Let's try.
Navicross
018
out
no,
Just,
not
give me
Trailblazer
a little
thing.
less
Navicross.
of the tip.
Navicross.
Good. Good.
Mm-hmm.
Even a little less if you can.
Even a little,
Because it's
yeah,
easy to.
that's-
How's that?
That
Let me
should be
feed
good
it.
enough. That's good
Let me
enough.
feed it. Let me feed it.
Oh, that's
You
good
have to pull
enough. You
back
already
a
made the bend.
You got to pull it, Ajit, if you can.
Yeah.
Yeah.
There.
Yeah.
Okay.
There
We're
you
good,
go.
we're good.
Very smooth.
Can someone hold that 7 French?
I got it.
Okay.
I got it.
Let me feed. Let go.
Yep,
Okay, now I got to feed this, brother. That's why.
Yep.
Hold on a second, guys.
Not pulling.
Got a lot of stuff here. So yeah, for those at home, what we're worried about is yanking on the aorta. What we're worried about is obviously losing the wire, stripping the wire. So now I'm feeding the wire. Ajit is going to pull now.
Yeah, that's a good point
Yeah.
because right now we don't have a sheath.
Right. We don't have a
Yeah,
sheet, so
we
you
don't
got
have
to
a
be
sheet.
very careful.
You want to be super careful.
Yeah, you got to be very careful with the aorta, guys.
It's coming easy.
I'm just feeding it very slow.
Yeah, I think that's a very important point that PK made because you don't have a microcatheter or a sheath and the wire is so stiff, you can actually shear the side of the aorta while you're going up. It's like
You can tear the whole
chiseling
iron.
it through it and
I
you
got
can
the
just,
wire. I got the
yeah.
wire.
You got it?
So I think you have to feed
Okay,
more
letting go.
and keep a little bit of tactile.
So now I'm gonna
pull
give me an
back on that.
O&A Trailblazer, guys.
PK, you
O&A
want- You
Trailblazer.
want to just feed it a little bit more?
Sure. That's good. And we'll put a
that's
Trailblazer
good.
up, and then we'll we'll put a better wire.
Let me clamp this.
All right.
Clamps
All
right
right.
here.
So now we're gonna switch out for a safer wire. Cycle a cuff gang for me, please.
But I want to reiterate that one more time. I think, because you have this wire here, you can shear the subclavian up top. You can shear the aorta, so you really want to be extra careful like PK is.
Catheters.
Yeah, that's why having
pull
the
it
catheter
back
in the
because
place
it's
really
not,
helps you.
right?
So it gives like a
But you gotta be
protective
careful with
sleeve
the
or a
wire.
coating over it.
That's true, yeah.
So what I'm gonna do is now feed this all the way
Front
down,
down.
and then we're gonna reverse exchange a V18, or actually a Spartacore, because we're gonna work.
But
now we're gonna do IVUS, so
PK,
we'll
do you
do a
want to
Spartacore.
do you want to do it? You think this is calcified, not calcified enough for you to at least balloon or something right now to create a track, or so that because you'll have holes from both the ends, or no? It's too long.
Well, I think it's better to do an IVUS. We have an IVUS available.
Sure.
And since we have an IVUS, I want to go with an 014 Spartacore. Okay. And then if it's calcified, then we'll go with one of the lithotripsies.
Yeah. Well, we also have an 018 IVUS which can go through a 6 strand, so that will give you better imaging, especially of the
straight,
iliac.
guys.
Yeah, no wire. From
System straight. No, don't pull the wire. Just keep it straight.
I'm just keeping it. We got the wire?
Okay, got wire. Just gently.
So now I'm going to externalize this, and we're going to refeed the V18 up. It's not coming. Wow. Look at this. There it goes. Good. Okay. Show me down. We're going to come out the sheath now. Rail guy.
Therapy, yeah.
Once we balloon, we won't need a through-and-through wire. So
right.
Yeah, that's
what we're going to do is once. No, you just push it up. It'll come out here. You don't have to worry about it.
You want to externalize?
Yeah, I was going to say, I think
initially externalize.
Once you create a channel, we should definitely get rid of the through-and-through wire because it's not worth the hassle.
It's okay, keep
Correct.
going.
Initially, the through-and-through actually helps because it gives you the supports, like especially with this calcification. But we are right. Once we do balloon angioplasty or lithotripsy of any kind, then you created enough lumen for you to work from below and not have a through-and-through and create any trauma you might do inadvertently because of this through-and-through.
Okay.
Yeah.
So now we're going to IVUS.
Actually really helps out.
Makes sense.
Now he's going to IVUS.
Now give me another clip, guys.
And then try to determine
Give me another clip.
the next course.
Take this.
No, just need another clip here. Oh, thank you.
So in terms
We
of
don't need to clip this side, no?
prepping this vessel, you're going to go straight with lithotripsy or you're going to pre-dilate
I think
first?
we should IVUS, right? Let's IVUS.
Yeah.
So, okay, guys. So now we're through and through cuff pressure, guys,
Well,
because we
I'll
don't
have
have
a low
aortic pressure.
threshold of doing lithotripsy in this case. If I have to, I'll just go up front with lithotripsy. I mean, IVUS will give us a lot
Flash
of
forward,
information.
please.
But the way the degree of calcification, we have some CT information, we have angiographic information, of course, confirmed by IVUS.
Yeah.
But for me, the threshold of doing lithotripsy here will be very low. I'll just
definitely
pretty much like
lithotripsy, but just seeing how that microcatheter even had difficulty delivering, you may have to pre-dilate just to open up the track.
Well, that was
a
my
little
question.
bit.
Do you think you have to do anything before the lithotripsy?
I think so, yes.
Let's see if the IVUS goes.
Let's see.
Not going. I'm having difficulty even pushing the IVUS.
Yeah, same.
I might have to.
Definitely pre-dilate.
I think we need to
That's
pre-dilate.
true.
There, IVUS
you
one. Okay. So we're in the aorta. Ready to record? Okay, pull back slow.
Arthic's protein shake work.
I didn't do it. PK did it.
No, Karthik was smart. He gave me through and through rail. There you go. Look at the level. So it's heavily calcified, guys.
PK uses a lot more brute force than I do. I think Ajit gave him a very false confidence. So.
Ajit always makes me feel like I can do it when he's standing next to me.
Yeah.
You know, I feel like
Whenever Ajit is around, PK uses brute force.
So
I've never
PK
used
very
Superman.
stiff, very calcified, all intraluminal. Not that it matters, but IVUS-wise, very calcified, narrow
All
slit
right.
margin right there.
now
And a
vessel
little bit
prep,
of,
guys. What do you guys think?
So I vote.
This probably needs balloon dilatation.
Yeah, I would say
Pre-dilate.
pre-dilate with like a 4
4 or
5
balloon.
balloon.
Yeah.
So do
then
you
shockwave.
think there's any difference between shockwave and seismic?
That's a.
I mean, we don't have a lot of experience. We're going to demonstrate seismic here today, but we don't have a lot of experience with seismic. I think Ajit and Vishal, you have the largest experience in the lab. I think Vishal has done 5, more than 5. Ajit has done 5. I think Karthik has done 1. I've done 1. Yeah. So, David, have you done any?
No, I'm looking forward to today.
So Ajit and Vishal, you guys tell us. Do you think the seismic will cross?
I think
I would still pre-dilate.
Yeah, I would pre-dilate. I think the
agree. I would
crossing
pre-dilate.
profile
Yeah.
has been similar to shockwave in the cases I've used. So, and I don't think.
Even with the through and through wire, you don't think you can push it
Well,
through?
I don't want to just like jam it and then push on too hard on the through and through wire. So I think there's a little downside in just pre-dilating.
Okay, so what size would you pre-dilate, guys?
Just a 4.
All right, give us a 4060 balloon.
I think that's a safer answer.
I think exactly. I think I agree with Ajit 100%.
Karthik is looking disappointed.
No,
He's like, just yank out the
I'm like,
through wire
I'm like Ajit is rubbing off his surgical aggressiveness on PK, and PK is rubbing off his defensive strategies on Ajit.
No,
Every time I see Ajit, he's becoming more and more of an interventionist.
Oh my God.
I would. I mean, listen. I believe in Boston's technology. I would have pushed it through.
I would have pushed it.
I mean, we can test it out.
I was going to say it, PK,
We can test
and then
it
you
out.
said we have the least experience.
Yeah.
That's why I didn't say anything. I was going to push it through.
Ray actually just gave me a kick in the back, saying, "What? Push it through."
That's exactly what I
All right, we can try. You want to try pushing it?
Give me an 014 balloon.
Ron is here. We have someone to blame.
Yeah.
Yes.
So we've got the Boston team supporting us.
Yeah.
We also have
have
the
a
Gore
16
team.
there, right?
Unfortunately, we got the B team from Gore, so it's a little tough.
Oh,
It's okay. He's not even paying attention. So.
guys, this is live.
So seismic. the reasons I like it and I started using it more is because it's a lot more customizable. So Vishal, I'll be curious what you think too. But
Well,
I
yeah,
think
he's
agree.
got a
You
good
can pick and
presentation on
choose.
segment.
okay, I won't steal your thunder.
So he's got a great
80%.
presentation.
The customizability is why I like it.
So by the time
let's-
we do balloon, I think he can do a quick presentation. By the time you just balloon it.
Well,
We
let's set the seismic up.
Yeah.
Let's open the seismic. Let's prepare it, and then let's do it. Good. It flew right through. All right, guys, a little 4-0.
Yeah, that flew pretty easy.
That flew pretty easy.
Guess we didn't
I
need
mean,
to
it's
do
a,
it.
it's
I
a
said.
0.4 balloon. It should fly.
Undersized, yeah.
Yeah. But it's just
This
when you
is
start
a
using
4
bigger
what?
size lithotripsy.
480.
Yeah, so 80 is a
Ready?
long size.
Just go,
It's okay,
Give,
it's a 4-0,
give me a
it's
little
not gonna
dive
cause
from the
much.
below, Karthik. So we're just gonna take a little dive from below to see where we are. Just to make sure how far into the. Okay, so it's quite long, so
Yeah.
we don't need that. But you can just undersize.
It's 4-0.
It's a
It's
4
okay.
okay.
Not
Let's
It's
go.
not going to touch
Yeah,
the
exactly,
normal
yeah.
walls.
Going up.
Just opening the track.
But the nice thing is it'll create a little channel, hopefully, so you can take a better picture too,
Exactly.
in addition to the trackability.
To support your
Corner.
point, like if you really push even
I'm at
IVLs
nominal,
like
8.
IVL
Corner.
gather, sometimes the balloon can get deformed,
Hmm
so you might not get the best
Yeah, I think it's just
IVL
the
effect.
profile,
step up.
especially in these cases, you want to use a larger size lithotripsy. It's not like a 4 or 5, or you use a 7,
We'll switch it
and that's where it becomes a
corner.
little bit more difficult and struggle.
Coronary, guys.
Yes, one second.
Yeah.
There we go.
Go up again with the balloon. I want to see the balloon. So the other thing, guys, when you go up with the balloon, don't just go up and down with the balloon. Inflate the balloon. Analyze how the balloon is inflating.
Correct.
So you get an idea. You see how you may be subintimal or subadventitial in that area, the way the balloon turns. So that could be an area. And this I learned from actually our very own Dr. Vayuka. So you see this little turn that we have. So this little turn could be the area where the perforation occurs because of the eccentricity of the calcium. So I think we're at around 8 atmospheres with the balloon, which is nominal. Now let's see if the pressure gradient changes. Can you show me the pressure, guys?
So
When you see this, the pressure gradient hasn't changed. You see that? So we're going to walk the balloon out. Let's walk the balloon out, see if the pressure gradient changes.
if you guys were in a dissection and you saw that on IVIS,
Now look a little better, but still there.
Yeah, it's better. I mean, of
Now, a
course,
little
with a
better.
4-0.
40 gradient.
All
30
right, what
gradient.
size is our IVIS?
7.8 externally.
Yeah, it's a 7.5, 7.8. Yeah.
So what? So you want to go with a 7 or an 8?
I would go with an
7.
8 peak.
7
I think
Seven.
7.0.
7.0.
7. Okay.
Some people do oversize lithotripsy by like 1 millimeter, but I just for the iliac, I would.
Iliac though, right? This
Yeah,
is
for
not
the iliac,
common.
I just
All
like
right,
to
let's
do
get
1-to-1.
it. So since me and Karthik are outvoted, let's go with a 7.0. What length is that, guys? 145. So let's set that up and show how to set it up, please.
You might want to give a little more wire.
So
push it.
on IVIS,
because
No, the
yeah.
I
length
guess the
of
other
the balloon
question
is
is,
6
are we intraluminal the whole way? And IVIS,
Always
I didn't
balloon.
see like we were in a dissection, but
Don't
But there
pull
was
out,
one
just pull it out.
area where
Not
you
pulling
could see a
it.
little bit of
Just
plaque
give it.
at
That's
like
plenty.
7 to 9.
I got that's plenty.
Maybe just a small area if, but most likely
So-
it looked all
So
intraluminal.
just
pretty
maybe you
much.
can go over the setup.
yeah, sure. Can we?
Can we focus? Yeah.
Yeah.
Can we focus on Dr. Rao, please?
So
We still can see
Yeah, yeah, very.
I'm just taking out the package here. All right, so setup's quite easy.
So what I would do now.
We can
I
see.
mean,
Can we
just-
get the IBIS screen out and make?
Very eccentric.
Here,
Yeah,
with the
better.
pigtail
Thank
from
you.
above.
So this is
Yeah,
the
beautiful.
perfect.
Now we
Thank
see.
you.
Okay,
Give
so
me
this
a
is the
pigtail
package it
from
comes
above,
in.
guys.
You can still
Yes.
So-
wire picker.
The end,
Yeah.
there's a cord which obviously connects to
Give me a
their
full French
system, the
picture.
seismic. So we give that to
Because
Ron.
you can always put
No,
a
but
And then-
if you
Copilot
side
to it
by
and
side,
keep
we
it.
do a
There's
4,
of
right?
course the actual
but-
catheter.
035 and 01. It's a 7 French, so it should be plenty.
And so it's exactly like other lithotripsy devices in terms of kind of the ports you'd expect.
And then you want to take
There's a
the wire out
stylet that you
and
take out,
Once we
and then we're gonna
you
flush
can't
it from the end. You mind
pull the
helping me
wire.
with
No,
that?
No, I know, but the pigtail from above, I want to inject. before
And
we
then
go
the
out.
last part here, which is in my hand, is just for the insufflator.
Let's see if it works.
So that's it. And then you just want to prep it really well, make sure you get all the air out, just like
Yeah,
right.
with anything
So
else.
like a 50-50 die contrast.
Yeah, so right now he has a 50-50 in that syringe, and he's
you can
aspirating,
before the
getting all the air out of the system. And that's it. And then once
Give me
it's
a
connected,
woolly
it's
one.
ready.
Mhm.
Most important thing is just getting the air out of the
Yeah,
balloon.
we'll just focus on the console. Yeah. once it comes in.
And then, is there any way to see that
wire first.
console? You're kind of
Let's go with the wire first.
hiding it. Might be a little hard.
So what we're gonna
But-
gonna do is, we only have a 6 French here.
But the
That's
console,
okay. You can go. You can
there's
still go.
A, B, C, D, E, which
Little
are the
bit more.
emitters,
Little
which
bit.
correspond to the
4 French.
emitters on the balloon. And so you can turn them on and off.
We can
It
see.
also has a pressure grade So it tells you how many atmospheres of pressure you're up to. So that way you can actually see the atmospheres drop as you're doing the lithotripsy. So you know you're opening up the vessel, and then you can re-inflate it to the pressure you want. You know, typically 4 or 6, and then it tells you the number of lithotripsy shocks you have left, basically.
So the difference, the major differences, if you were to summarize, what would it be, Ajit?
So it's all customizability, in my opinion. You can turn, the big one is you can turn on and off the emitters. So if you have a balloon that's longer than the lesion, you don't have to necessarily put in the lithotripsy in all the emitters. You can turn it off, and then you can save those for later on. And then you have the pressure gradient, so you can see that on the screen as well. So I think those are the advantages. Vishal, do you have anything else?
No, I think that's pretty much what it is. Just selecting the amount, the lithotripsy points. You can select all, one, or none, like depending on where you want to focus it. So that way it gives all the energy at that specific point. So that's the biggest advantage you can choose. So length might be compromised, but at least your emissions are controlled under you yourself. So I think that's what gives the real kick with seismic. Otherwise, it works the same way as.
So 4 French, Dame?
Yeah, 4 French.
Yeah.
So I'm going with a 4 French pigtail from above so we can visualize. And guys, this is all about safety. You see the eccentricity of the balloon inflation. So now you want to be able to see from above. So I've got through and through wire all the way down, right? And now I've got a pigtail from above so I can see. So now what I'm going to do is I'm going to inject my where is it?
This one.
Yeah, this one. So sorry. My injector up top. So this way we're going to have a little bit of visualization, and we're going to have a through and through wire. Come forward, brother.
And this is the part once you start doing kind of,
Good.
lithotripsy, things like that, you have everything ready to go in terms of your covered stents in the room.
Okay, so now we're going to rail, and we're going to take the lithotripsy forward.
Okay,
Who's
no
got the
wire
rail
quite yet.
Wire's not up. Is it coming now?
Not yet.
No?
Still no.
Still no. Wow. No.
Almost.
I think the other thing about seismic is that it's laser based and not ultrasonic based, right? So what they're saying is that the energy delivery is more equal. Like, have you seen any
Ready to
Well, I mean, like I said, it's just preliminary work. We've seen good results with it. Of course, patient selection is important, and then calcification. But
So, Ajit, what do you think about the positioning? What do you guys think about the positioning?
Maybe in a tiny bit more?
Yeah, I think it has to go in. I think, look, Karthik, he's going to the other side for us to be able to see. Again, we're going to inject again. Inject.
That's good.
I think that looks pretty good.
Okay.
Yeah.
Then the next question is whether we need to turn off any emitters, but I just keep them all
I
on.
think they'll keep them all on.
The size is
To 7.
7
what
60.
length? 60.
Yeah, so that's also a good point. So we know what size stent we need.
57, I think. It's
Okay.
Not gonna
So I'm going to go up.
No, I'm
4.
saying you can use a 57.
Okay.
VVA.
So you know what shockwave, like the more centralized emitters have the more
most
powerful,
Correct. This is differential is the same.
So they're all the same. Okay.
Yeah.
Gotcha.
So I'm going
See
to
again.
4 atmospheres.
He's feeling the
look at
pain,
that
guys.
I'm going very slow.
Yeah.
Okay, we're at 4, and then do you mind hitting that button for me?
Pain. Oh, he's bradycarding. Okay, stop. Down. All right, we're going to have to give 0.6 of atropine. Not yet. Hang on. Let's talk to him. Ray, talk to him. Tell him not to bear down.
Yeah.
So again, guys, that's a very important point. When you go up in the balloon, with these very, very calcified lesions, they can become bradycardic. And so therefore, it's important to recognize, have a fantastic nurses like Denise and Reka, so to be able to do it.
Take a one shot.
Ready, go up again?
Yeah, obviously
Take
keep
one
an eye on the
picture.
pressure too.
Just to make sure.
So no extrav that I see.
Nope.
So we're going to go up again.
Okay, we'll try that again. We'll go slow.
Okay, now tell him to breathe out because he's going to feel it. Don't bear down. Okay, he's bradycarding again. So I'm going to have to give 0.6 of atropine.
Yeah.
0.6 of atropine, guys.
So should we go with the smaller IV on this situation or slower inflation?
No, I think it's just
We did go err on the side of caution with the 7 because it was the vessel was a little
I think Karthik and I approve wrong.
No, I think it's nothing to do with the size. I think he's just sensitive in that area.
Well, I
And
mean,
I just don't like the eccentricity of that balloon, as
Correct.
TK
I
was
mean,
saying. It's like,
like Dr.
So-
Bayuka taught me many years ago,
Yeah.
that this eccentricity is incredibly important in these iliacs.
Yeah. for
And
sure.
I think that this is a very important illustration to everyone. Everyone out there probably saw this lesion and said, "Oh, it's such a simple lesion," and quote unquote it is. But you see all the complexities that go through it, and I think that's why a teamwork and an understanding is very important. So we're going to go up again.
Question: do you want to get the stent open and
Yes.
Yeah.
wire-
Okay. Let's
Yeah.
get a VBX, guys.
Steven
Okay.
Kraft.
Oh, before we go to that, we're going to go to your talk in a second. Let's talk a little bit about. Why don't you start your talk while we do this?
Yep.
Let's go to the talk, and then we're gonna for
try it
everybody at
again?
home, we're gonna balloon this
give atropine.
while Sanchit presents his presentation. Go to the presentation.
you want to go again? They give
Not yet.
atropine, no?
Atropine is in. No, it's heart rate's not up. I wanted to go over 100.
Okay, so
You give atropine, no?
here
Yeah, they give it.
I'm going to talk about a little bit of the evidence surrounding the aortoiliac interventions. We have the COBIS trial, which was a randomized trial looking at bare metal stent versus a covered stent in the aortoiliac space. It was 125 patients and 168 iliac arteries and aortoiliac occlusive disease. It was head-to-head comparison. And what we found in that trial was the patients with lesions of task C and D classification, that is the more complex classification. In those patients, there was a significant benefit using a covered stent with a 5-year primary patency of 74.7%. That being said, it is important to remember that this was a subgroup analysis and there was some attrition in the follow-up, but the advantage still stands of a covered stent in the aortoiliac occlusive disease for task C and D lesions. Then came the Discover trial, which also looked at bare metal stents and covered stents. This was also a randomized control trial of advanced common iliac artery lesions, not aortoiliac, but CIA. It looked at 174 limbs, and there was randomization. There were stenosis of more than 3 centimeter or occlusion in the common iliac artery. And the endpoints looked at was freedom from occlusion, and it was 96.4% versus 95.0%. So the results of COBIS were not reproduced by Discover. It was not it was a finding that showed that both bare metal and the covered stents perform equally well. However, it is important to recognize that the lesions that they studied were different, with more complex lesions in the COBIS trial. So the take home from this is that covered, although not mandatory for every CIA lesion, should strongly be considered for a very complex calcified task CD aortoiliac disease. I can't move this forward for some reason.
Can you go? Yeah, they can go next.
Can you go next, please?
Next slide, guys.
They're working on it.
You have the wrong slides.
Why is NYTBS showing?
Yeah, yeah. What?
That's not part of my slide. I think that's just the desktop they have. You just have to go forward. If you could.
We're still working on the slides, I think.
Okay. So let's wait.
All right, let's see in the meantime what.
Ivis, let the grips go. Ivis.
Yeah.
Can we have these slides, guys? So you can see we did lithotripsy, we gave atropine, and the heart rate was held as we went up. And now we've done lithotripsy, and you can see the blood pressure, as Damien is pointing out, that shows that the gradient is a lot better. So now we're going to do an IVUS as our AV team looks at this. What's the name of the AV company?
Broadband.
Broad what?
Broadband.
No.
Broadband.
So, when I get this, I want to get this chance to thank Broadmed for the work that they're doing with us with this. It's amazing the ability of them to be able to transmit these live cases while we're doing this. So let's go with a IVUS, please, while Broadmed fixes the AV. Let's go, IVUS.
Yeah, it's on. It's on.
We're on record.
We're on record. Go ahead.
Yeah.
Pull it.
Can we see the IBIS screen, please?
show us the IVUS guy.
Yeah, that's
thank
it.
you.
Perfect. Thank you.
Pulling back, you can see there that there was a little bit of
dissection.
still a little bit right there. You see that? So, and then coming down. But definitely you can see the calcium has all been cracked. And now we're all the way down. Okay, good. So now we're going to we're going to get the VBX ready as Broadmed fixes that. So Sanchit, is there any difference between VBX and Livestream, and what are the characteristics of VBX or Livestream that you like or don't like?
So VBX is the covered endoprosthesis, which I think is balloon dilatable, and especially in the
but both are balloon.
Both of them are
both of them are balloon dilatable.
Both are prosthesis.
But it's okay. Let Ajit or Karthik talk about it. Karthik.
So I think VBX and Livestream. I think the main thing is more of a radial support. I think on my end, they're both covered stents from different companies. I think VBX in general, I think, is known to have a little more radial support in terms of calcium to hold it. Ajit,
I think there's a couple of more things, Ajit, right? There's flexibility, deliverability, and also the conformability. And
conformability is better for VBX.
Yeah, the stents, the stainless steel struts are separate, so that gives them a little conformability. So we use VBX a lot.
No, also the fact that you can tailor the VBX, right?
Yeah. And they have the 8L, which you can take to 16. So that's another.
And also you can dilate the proximal aspect if you have a dilated area, and then you can keep the distal. I think, a lot of advantages to both, but I think VBX in this case is the one we're going to use. Okay, so.
This is what, 50?
The slides are up.
79.
Should I proceed with the slides?
Well, let's take a picture.
Okay.
We'll decide. Take a picture. Don't worry, we can take a picture. Ready? Let's take a picture from above and below. I'm going to first flag up above. Hold on. The slides are ready?
Yeah.
All right, go with the slides. Go with the slides, please, while we set it up.
Please. Okay, so moving on with the evidence in the space, we also have the VBX Flex pivotal study, which was a single-arm, non-randomized trial, which looked at 1-year patency and then 3-year data following up. It was, like I said, a non-comparative study. It looked at contemporary balloon expandable covered endoprosthesis of the VBX and showed complex anatomy was included and kissing stents. It did show early device performance and it showed good patency even at 1 and at 3 years. And then we have a new trial which is ongoing in the space, which is called the Forward trial. It is comparing the VBX versus bare metal stent for complex iliac lesions and CTOs of 4 to 11 centimeters. The trial is currently ongoing, and it would be interesting to see how these two perform head-to-head. This trial is randomized, and it has a core lab with the central clinical events adjudication. Okay. That was the evidence slide so far. Let's talk about, should I talk about the seismic as well?
Yeah, please.
So seismic differs from the IVL shockwave in multiple ways. It is considered to be a little more deliverable than the IVL shockwave. It has a directional therapy. The mechanism of action is different from the IVL. It has a dual mechanism of action. The first is that there's a laser energy that emits, and then that laser energy hits the metal on top of the balloon, which creates an initial pressure wave to fracture the calcium. And then there's a secondary cavitation bubble, which expands that said fracture. It has multiple points from where it delivers that energy. This is the difference. As you can see, in the seismic, all emitters emit the same amount of energy, while in other devices, the energy is sort of skewed and unevenly distributed. Okay. We can go back to live.
All right, so you guys saw that the seismic device, did you go over the data as well with that?
No, just the mechanism of action and how it works and everything.
So again, we know that in the, Vishal, maybe you can go over the data with that a little bit.
Yeah, so I have to look up. I don't remember the exact numbers.
Numbers on the VBX?
It's too high, man.
A little bit too less.
Tiny back.
Yeah, it's tiny
Like
back.
half a millimeter.
So you can see here we're landing the stent appropriately.
One more picture.
We're landing the stent appropriately. We have a 58 VBX. That's perfect. We have a 58 VBX, and we're going to go up. I'm okay there. Go
I
up.
think it's okay. I'm going to go up.
It forces
What's
a
nominal?
little bit when you go
Yeah.
higher with the balloon. So just going a little
okay.
tiny bit.
Yeah.
I'm going up to
No,
7.
good.
Yeah, that's
I
good.
moved it slightly up.
Yeah,
Mhm.
perfect.
Mhm.
And remember, we're going to
Watch
take
the
an
heart
echo.
rate to our nurses. He's sleeping, but it could still drop.
Perfect. Next part.
Still catching up every time I go to 7. When you
So now it's a 7 or VV exercise, right?
Yeah.
7-0, 7:59,
What is nominal?
7, which
7.
I'm almost at.
I would go to 8, 9 here.
Okay.
Yeah. There you go. All right, save that image. So one of the things you also want to do is before Ajit comes down, you want to go to different views to see how the stent
Balloon
is
expands.
expanded. And you can see here, even though VVX is a great device, however, you could have malexpansion in certain areas down. So therefore, if you want to do it, Vishal, we're still waiting for the data.
Oh yeah, sorry. So no, I was just seeing that. So I mean, seismic has both data, both above the knee and below the knee data. The initial data was mostly suggestive of the efficacy
Don't take one
endpoint, which
picture.
was
Sure.
residual diameter stenosis. So there was a significant improvement in
It's hard
residual
to
diameter
inject from above.
stenosis.
Let's inject from
From a
above.
safety endpoint, they had 100% freedom from major adverse events at 30 days. So
Not
both
no
from an
perf.
efficacy endpoint, it met a target, which was
Careful,
residual
coming out is a pain in the neck.
stenosis, and from the safety endpoint as well. Same thing with below the knee data, which was mainly intentional treat.
Okay.
They showed
Above it,
significant
yeah.
improvement or significant reduction is the residual stenosis with the 100% freedom from major
From below,
adverse
brother.
events. So actually the device has demonstrated safety and effectiveness in patients who had severely calcified
Perfect spot.
lesions as well.
Nice.
It's not expanded up top.
No, it's not.
The
You have
population
to do an
size
8
was like above
That's
the knee
where
was
your
almost like
dissection
I think
plane is.
95,
So, yeah, you should
90
not
to
bad, though.
95 people. Below the knee they had a smaller
Maybe.
data.
Great.
I mean, it's a smaller
Yeah.
amount of usage, which was just 18 to 20. But like I said, the technology, like you said, is a little bit different from the previous lithotripsy, which was the shockwave. This is more laser-based, more controlled with a bubble in it, and with different points firing pretty much at the same intensity as compared to the ultrasonic technology. So mechanism of action is a little bit different, but the data itself, especially from a safety standpoint and efficacy standpoint, is pretty convincing. But I think, like you talk about, most of these lithotripsies are not like your final therapy. It's more about your adjunctive therapy and how well they
Lesion
do.
prep, yeah.
And their goal is to see the dissection and their residual stenosis, what they are looking at. Like in the lithotripsy arm, in the shockwave, they were more concerned about less than, they had a 77% reduction in type C, type D dissection in the when they did the
Definitely
shockwave
go up.
IBL.
8 of
In the seismic, they looked more
Definitely
about
became
the
8 of
residual stenosis and, of course, making
8
sure
of
there are no
40.
complications.
Yeah.
Dorado, if you have. Yeah.
Oh, can we see the IVUS? Sorry, we couldn't see the IVUS screen. If you're IVUSing, we'd love to see that.
All right.
So-
So play the IVUS again, my dear.
Yes, please.
She's playing the IVUS. So you can see that by angiographically it wasn't expanded properly. So IVUS, we went in and you can
Right
see
there.
again. That's the ostium right there. See that?
Yeah.
So
Little info.
the problem
40.
you have to be careful, and Ajit can talk about the foreshortening, because with VBX, right now there's two questions that I got to ask for our senior team. David, you don't have a gradient. Okay, would you balloon this?
So
Because you don't have a gradient.
That's a question that I was going to ask, is what the gradient is. If the gradient is resolved in this particular situation with the proximity of that collateral there, I probably would leave it. That would be my opinion.
What about you, Ajit?
Well, as an interventional cardiologist, I'd leave it alone and be conservative. No gradient, not even close to 30% residual stenosis.
Exactly.
And then the problem is, I mean, in this case, we didn't perforate, but if you did, the seal zone's not great. You know what I mean? It's
Yeah,
not like you have
right.
2 centimeters.
No, I'm
So
going to pull it back
just want to
here.
be careful of that. But
Well, we've
But it
got.
looks like we're done.
Yeah, but it looks like
but we're
well,
going to do it, and
we
there's
are
no
doing it, though.
perforation.
Karthik and I decided to outvote everybody because, we're interventional cardiologists.
We have Ajit in the room.
we have Ajit in the room. I have nothing to worry about.
And we have more
Yeah,
VPX.
Go up. So what's
Yeah, I
nominal
think
with the...
that a little bit of infolding, you're right.
8.
I mean, a little bit of infolding right there and getting your true covered stent up there. I think this 8.0 is, I think, a good side. We're not like going crazy on it. We're not going from a 7 to a 10.
Keep going.
We're just trying to do a
6,
little bit
8,
more
8
balloon
atmospheres.
dilatation, especially with that inflow.
can
being
go in
happening.
one
So I
down.
think 8.0 would be a good
Down?
decision.
No,
So
we're
my
going to the aorta.
concern
You don't want to
there
go
is,
to the
wasn't the
aorta.
dissection plane also around that edge? So you
Yeah,
don't
that's
wanna-
why it didn't
Yeah.
come out of that. That's why it didn't
Correct.
come
That's
out
why
of the
that's the
balloon.
center part of
Yeah.
the
Yeah, go up again.
right there.
But-
I think we're not going to be able to expand this because I think that we're either going to dissect proximally by trying to expand it, or we're going to, I don't know, or it's going to foreshorten and we're going to perforate. But let's see.
Yeah.
It'll be interesting to see what happens.
But on a
10,
7-0 with an 8-2
10.
balloon, the foreshortening is not
Okay,
that significant. If you had to go from a 7 to a 10, then of course there is foreshortening on both the ends. But in a 7 and an 8-0, I don't expect much foreshortening
Let me
whatsoever.
balloon down here.
Yeah, that's a great point. And I think in the VBX in general, foreshortening is a lot less than other,
other device, exactly. Yeah. Even a live stream, you can actually go up on the side, but it foreshortens.
4, 6, 8.
So both of them do.
8 is fine.
That's
down.
8 on.
All right. So now we're done with this. So now we're going to check our gradient. Careful. Good. All right. Let's inject from below, Karthik. Ready?
Yeah.
Just below?
Yeah, I just want to see how the edge looks here, Ajit. Okay. So I'm going to pull this sheath back a little. And I want to remember, a lot of times, the patency of these stents is inflow and outflow, right?
Yes.
So we're not fully opposed. We're fully opposed. Yeah, we're fully opposed.
I mean, on the IVUS, it's fully opposed.
Happy with that, Ajit?
Yeah, I'm happy with that. I think it looks good. And we
notice, everyone, the internal iliac is back. So Vishal was wrong. And
I just said the internal was there. That's what I said. My first statement was the internal is there. What is it?
All right. Okay. All right, so I guess we're done here, right? I think everybody happy. We're going to do some runoffs, and Karthik will leave us offline. But I appreciate, all of you joining us. It's 9:05. More importantly, really appreciate Ajit taking the time because obviously he's got an OR schedule and he's here along with all the rest of us. So thank you, Ajit. Really appreciate you.
Of course.
And Vishal, we're going to sign off from the Cath Lab. Please recap. And Sanchit, great job presenting.
Thank you.
Perfect.
Right.
Thank you, PK, Karthik, Ajit, everybody right there. Thank you for joining us. Thanks, David, as always. So for all the viewers, we're going to be back again in September 4th week, which is September 23rd for our live case, which will be immediately followed by our New York Endovascular Summit starting on September 24th. So we're excited to present not only a live case, but we'll have at least 7 more live cases during our conferences from all over the world with like I said, the world-renowned experts pitching in, giving their expertise, discussion, and of course, including from diagnosis to management therapies. So we'd love for you to join nyebs.org, registration link. Otherwise, we'll see you here in New York next month. Till then, have a pleasant summer.